All right, looks like we are live. Hello, I'm Deepak Bhatt from the Mount Sinai Fuster Heart Hospital, and you're here for the American Heart Association conference recap, focusing on key insights for thromboembolic disease prevention. We are live on Twitter, I guess it's called X now, and Facebook and YouTube, and maybe a couple of other social media platforms. And I'm lucky to be with two great friends and colleagues, Dr. Jeff Barnes, who is Associate Professor of Internal Medicine and Vascular and Cardiovascular Medicine, and the Director of the Vascular Medicine Fellowship at the University of Michigan in Ann Arbor, and Daniella Kadian-Dodov, who is Associate Professor of Medicine and Vascular Medicine and the Program Director of our Vascular Medicine Fellowship here in New York at the Icahn School of Medicine at Mount Sinai. Welcome to you both.
Hey, thanks so much.
Well, we're going to go through some trials in rapid fire. I think we've only got about 15 minutes or so, and hopefully everything will work well. I'm not superstitious, but it is Friday the 13th, and we're trying something novel and interesting here. But let's start with a quick recap of some thromboembolic disease trials. First, starting with peripheral and coronary artery disease, and we'll move to venous thromboembolism and pulmonary embolism and atrial fibrillation. So let's start with the 2024 PAD guidelines. And maybe, Daniela, we can start with your impressions of what was hot, what's important, maybe how they differ from the Europeans.
Yeah, thank you. It was a big year for PAD to have two major guidelines come out, so very exciting to see. I think the big takeaways is we saw the integration of data from the Compass and Voyager trials into this integration. The big difference is that the combined low-dose rivaroxaban with aspirin therapy for patients with symptomatic PAD got a 1A recommendation in the US for reduction of MACE in male, whereas it was a 2A in Europe. I've spent some time thinking about that. It confused me a little bit when I saw it, in all honesty. I think it might be because they're looking at the PAD subgroup as not necessarily a true randomized controlled trial, because it was a subgroup. That's the only thing I could think of. And then the other big difference, not necessarily thromboembolic, was the lipid target was different in the European and the US guidelines. But Jeff, what do you think about that difference in the recommendation?
Well, first off, Daniela, I think it's so important that we finally have a guideline recommendation strongly endorsing the use of that dual pathway approach, the rivaroxaban 2.5 milligrams twice a day, plus a low-dose aspirin. I agree with you. The difference between a class 1 and a class 2A is sort of an academic difference. I think they may have been swayed in Europe by some of the bleeding data that we saw, particularly from the Voyager PAD study, but they also mentioned that that was really in patients who had prolonged courses of clopidogrel after PAD revascularization. So if we keep that course of clopidogrel really short, less than a month, patients tend to do pretty well. And finally, we have an intervention that reduces limb-specific events. So I think it's really important for the field, and I'm glad to see we have these guidelines supporting that therapy.
Yeah, I'm really excited by both data and guideline advances in the world of PAD. It's really exciting. And yeah, even though there's some differences between the US and European guidelines, in general, I think they're saying use more in appropriately selected patients, antithrombotics, and more intense lipid-lowering therapy. Well, let's move on to EPIC-CAD. That was, I thought, an interesting, well-done trial, potentially quite influential, but more importantly than what I think. What do you think, Jeff?
I agree. It was a really important trial published in the New England Journal, really comparing a DOAC, edoxaban, as monotherapy versus combining that with a single antiplatelet in patients who have AFib and stable coronary disease, meaning revascularization that was more than 12 months ago or is currently just being medically managed. And what I found so striking is how quickly the curves for both their overall primary composite endpoint, but also the bleeding endpoint, they diverged right away. And there was a striking difference. Actually, it was about a 10% absolute risk reduction in bleeding, in particular, in the group that got the edoxaban monotherapy compared to the edoxaban plus single antiplatelet therapy. Really no difference in the thrombotic events, so we're not seeing any harm, but clearly you can see bleeding benefit if you drop that antiplatelet in those stable CAD patients. It reminded me a ton of the FIRE trial using rivaroxaban from several years ago. So I was excited about that. I don't know, Daniela, what your take was.
Yeah, no, I agree. I think the one thing that I thought about when I saw that is that this really was in an East Asian population, and we know that the bleeding and ischemic risks are different in the East and the West, and so they're known to have a lower ischemic risk and higher bleeding risk compared to Western populations. So I wonder if it's fully extrapolatable to everybody.
No, I agree with you. That's a great counterpoint, though the consistency of the two trials really is quite remarkable, but the need for perhaps greater geographic representation and validation probably still exists. And there are still trials ongoing looking at this topic. All right, let's move on to VT and PE, a topic I know that both of you love. Jeff, maybe you could start with a quick recap of OncoPE.
Yeah, I was so excited to see this presented at the AHA this year. This was a trial in patients who have cancer-associated VTE, looking at different lengths of treatment with rivaroxaban. Should they get a 6-month course, or should they get that extended 18-month course? And again, this was conducted over in Japan, so we got some great data there. Again, what we see here is this marked reduction in bleeding, marked reduction in recurrent PE. So really, the longer you stay on anticoagulation, the better you do for preventing PE. What was really unique about this trial is that the bleeding numbers were similar. So it really sort of supports that notion that if you can tolerate being on an anticoagulant, because we know the bleeding risk tends to be concentrated up front, then extended courses tend to not increase bleeding over the long term, but they have huge benefits in preventing recurrent PE, really helping us think about how long we want to treat these patients.
Yeah, important findings, I thought. What did you think, Daniella?
I completely agree. I think this was a really interesting and important study. And you know, it was notable that they managed to reach statistical significance, even though they had really low recruitment due to COVID and only reached about 50% or so of their anticipated population.
Yeah, terrific. Well, Daniella, maybe we can stick with you. What do you think about the Peerless trial?
Yeah, so this was a really hot, exciting trial that was presented at TCT this year, looking at large bore mechanical thrombectomy compared to catheter-directed thrombolysis for patients with intermediate risk PE who had a proximal clot that could be accessible by large bore thrombectomy, and one other risk factor, which was either an elevated troponin, cardiac disease, including CHF, chronic lung disease, and vital signs that were elevated or indicating the patient was sick. The primary endpoint was a little more complicated than I think you typically see. It's this hierarchical win ratio, which basically you kind of move down the list. If you don't hit number 1, you move to number 2 to number 3. So this composite included number 1, all-cause mortality, intracranial hemorrhage, major bleeding, clinical deterioration, bailout, and then post-procedural ICU admissions and length of stay. So the primary endpoint as a composite favored large bore mechanical thrombectomy over CDT. It was really carried by a lower rate of clinical deterioration and longer ICU stay in patients that ended up getting the CDT compared to large bore mechanical thrombectomy. Importantly, there was no difference in mortality or bleeding or major bleeding, which I think is really probably one of the most important takeaways from this. And no real difference in long-term outcomes of dyspnea, although in the short term, within 24 hours, patients reported feeling better after the large bore intervention. I think this is great to start having some of this data coming out. I'm really excited for the other trials on the horizon, HiPitho, PE Tract, that will help give us some answers about how to best manage these patients. The one thing this doesn't answer for us still is really who we should be intervening on. And I think that's the overarching question in this space. And I don't think we have any really strong data. I'm sorry about that.
No, I said, you're right. That remains a really big question.
Yeah. And I don't think we have real data about which therapy to recommend over the other yet, but this is a step in the right direction.
Jeff, is it enough to change your practice in any specific way? If so, how?
Yeah, it's not changing my practice because it hasn't answered the question, who needs an intervention? But what it actually does for me is it supports my choice to use either a catheter-directed thrombolytic approach when appropriate, or a mechanical thrombectomy approach when I need. And I think it helps us say, look, the bleeding outcomes, the death outcomes were no different. It's really going to be in some of those other outcomes where we start to see some differences. I also think it's really important that clinicians start getting familiar with this win ratio. My sense is we're going to see it increasingly in trials. And so it's something we're going to need to just learn how to understand, how to interpret, and then apply to our patient care.
Yeah, great point. I mean, I'm involved with a number of trials, I'm sure you both are as well, that use the win ratio as the primary endpoint. Regulatory agencies like the FDA seem much more accepting. So yeah, folks in practice probably do need to learn more about it. All right, let's move on to our third and final disease state, atrial fibrillation and the option trial. Daniella, maybe you can recap that one.
Yeah, sure. So this study was presented at AHA. It looked at about 1,600 patients with atrial fibrillation and an elevated CHA2DS2-VASc that was at least 2 in men or at least 3 for women, in patients that had had a catheter ablation. And they were then randomized to either left atrial appendage closure or oral anticoagulation alone. Important to know that those that got the closure device still got oral anticoagulation for 90 days and then were transitioned to aspirin therapy. And patients were followed out to 36 months. The primary safety endpoint was non-procedure related bleeding or clinically relevant non-major bleeding, and it met superiority. It was lower in the left atrial appendage compared to oral anticoagulation. Very interestingly, it was quite a high rate of bleeding in those receiving anticoagulants, about 18%, and 8.5% with the closure device. The efficacy endpoint was non-inferiority, and it was composite death of any cause, stroke, or systemic embolism. Also, it met non-inferiority for the left atrial appendage closure. And then lastly, the secondary endpoint for major bleeding was statistically lower in patients with left atrial appendage closure, and this was a non-inferiority endpoint as well. So it seemed that left atrial appendage closure did a nice job of reducing the embolic events at lower rates of bleeding compared to continued oral anticoagulation.
Great, Jeff. Bottom line, will it or won't it change your practice?
I think it will. It's making me more comfortable in recommending left atrial appendage closure, particularly in patients who either don't want long-term anticoagulation or have some reason that they can't tolerate it, such as bleeding risk. I'm not yet ready to jump to that as my first line therapy for stroke prevention in AFib, but it does make me more comfortable using it when appropriate, especially those high-risk patients.
No, that seems like a really balanced sort of way of interpreting it. Well, we've only got a couple of minutes left. So Jeff, maybe we can stick with you for a quick recap of Brain AF.
Yeah, this was a really interesting study also presented at the AHA meeting this fall, really extending another one of these questions we've asked, which is how far do we go with anticoagulation in an AFib population? These were patients who had AFib, but they were at very low risk of stroke, excluding those with prior stroke, heart failure, diabetes. So, really low CHA2DS2-VASc scores. The mean age was in the low 50s. And they asked, could we give anticoagulation as a way to prevent cognitive decline or stroke events? And unfortunately, we didn't see any benefit here. Both the cognitive decline rates were low and similar, about 6.5% to 7%. And the stroke rates were pretty low, about 2.5% in both groups. So really another strikeout for expanding the use of anticoagulation in a low-risk patient population with AFib. We've seen similar things with some of the high-rate electrical activity to pick up. So really focusing anticoagulation just on that tried and true AFib population for right now is how I'm reading the data.
Yeah, that's good advice. Use the drugs where we have great data. How about you, Danielle? Any thoughts about this one?
No, I completely agree with Jeff's bottom line. I guess the one other thing I'm wondering is clearly there's something contributing to cognitive decline in these patients, and perhaps it's not embolic as was thought. There may be something else going on that we just haven't uncovered. So yet again, I would say one question begets 3 more in medicine, but yeah. Very interesting data.
Yeah, no, absolutely. We've got to keep looking for ways of preserving brain health. It's a big challenge of this next decade. All right, well, to the audience, thank you for participating in this activity. Please go ahead, if you haven't already done it, and scan that QR code to claim CME credit. You'll see it there popping up on your screen. And Jeff, Daniella, it's been a wonderful conversation with you both. I hope our audience got a lot out of it. I certainly enjoyed hearing both of your perspectives on these important trials. It's a nice way for thrombosis to close out 2024.
Thank you.
Yes, thank you both, and thank you to the audience.